So both of them, of course, German trial, we cannot expect much here, we're only 150 patients. Upper esophagus was also included in these patients, and they have given only 40 gray in 20 fractions. Still, they could not find any overall survival by doing surgery in these patients. So only definitive chemo-RT may be enough. And the French trial also did not show any overall survival benefit. This is one trial which we can really bet on, because these are mostly thoracic esophagus patients, below the carina patients. Majority of them are squamous cell carcinomas, and concurrent chemo-radiation has been very good, and we did not do surgery after neoadjuvant chemo-RT. So in spite of doing a different kind of schedule, it was not the routine 50.4 gray, it was a split dose of RT which was used in French trial, but still we could find that it was equally effective compared to. Then the next one is whether should we add radiation or just continue with FLOT. So FLOT definitely has made a huge impact in adenocarcinomas of GE junction. So we have seen that there is a good response, and even after patients who are above 65 years age also, if we manage the toxicities very well, then FLOT is supposed to be much better than any other treatments, and that has really changed the practice. Then should we add, what are the subset of patients where radiation can be added? So we have evidences from NeoAegis and Top Gear where they have shown that there is no difference in overall survival, but still the, if we see the Checkmate trial also, there, adding nivolumab has definitely improved survival. But what is important here is, if at all we have a patient who's not fit for FLOT, then can we do cross plus Checkmate, and that is doing neoadjuvant chemo-RT followed by surgery with Checkmate, will it give an equivalent result to FLOT? So this is really thought-provoking, because if we see the ESOPEC trial, the survival analysis starts from the time of treatment, but for Checkmate trial, it starts after 10 weeks of surgery. If you can synchronize the times for this FLOT and this Checkmate trials, the overall survival will be same. So maybe in future, we have to see such kind of trial where cross and Checkmate has to be compared with FLOT. Till that time, I think we will leave the lower end of adenocarcinomas who are fit enough. They can go for chemotherapy followed by surgery. But if you have a locally advanced cancers, because sometimes I was just talking to Dr. Bada, where patient who has a very advanced disease who is not fit for FLOT, those are the patients where we can put up with chemo-radiation upfront, because adding only chemotherapy might not give sufficient changes, sufficient responses. In those cases, maybe we can still go ahead with chemo-radiation, even if it is adenocarcinoma for the lower end of the esophagus. Then high MSI, does it benefit? And we have seen that perioperative chemotherapy doesn't have much benefit in MSI, but it has a benefit with immunotherapy. So maybe adding radiation might be beneficial, but we also need to see this prospectively in other trials. So RT dose volumes are much better than compared to what it was earlier. We used to treat at least 5 centimeters above and below, but now with all the good imaging techniques, and also the the volumes have come very precise now. It's only 2 to 3 centimeters above the GTV, because we have good chemotherapy regimes, and also the PET scans are also helping us to delineate the GTVs very precisely. And because of these reduced volumes, the surgeons are more comfortable even after, if we have any residual disease with the salvage surgeries. And always respect the anatomical boundaries when you are doing the radiation fields. We'll not go into details of this, but for upper esophagus, don't forget to add radiation to the supraclavicular area. So to conclude, RT definitely has some role, especially when we have a locally advanced esophageal cancer in the lower end GE junction, where it will add definitely some benefit compared to only chemotherapy. Thank you.